This program it's somewhat depressing to listen to this program, only to the extent that we're talking about patients who have decided to end their life, or they're at that stage where it's just too much and they can't do it. And so sometimes it can be a little unpleasant to listen to, but how can we avoid them from hurting themselves once they are within our care? So let's go ahead and start. I want to just do some information backgrounds on suicide. The U.S. has the highest suicide rate of all the wealthy nations in the world, and it accounts for almost 14 deaths per population in our country. We spend 17% of our domestic gross product on healthcare. Now, this came from a 2020 article from Commonwealth that shows, and by the way, when I go through this program, I'm going to be giving you various numbers, but you're going to see they're very close together. And you can see here from this graph, it shows how high we are in relation to other countries. So what are those who are at risk for suicide? Men, veterans, those who have other mental health conditions. Of course, we have our substance use disorders, traumatic brain injury. Those tend to have a higher rate of suicide. We also see it in a certain age factor, and that is over age 45. We already mentioned the schizophrenia, the other behavioral health issues, chronic pain patients, environmental factors. We see this a lot within the kids, where we have bullying that results in them ending their own life. There's also access to lethal means, whether it's drugs or firearms. And then there's also the historical events, whether it's a previous attempt, child abuse, other trauma that would lead them to this. So look at the areas, especially that behavioral health patients are treated. Where are they? Do you have a dedicated unit? If not, do you have it in the emergency department where you have a special room set aside for behavioral health patients? What about environmental risks that come up? So you need to do an assessment, have some kind of strategy to go through your facility. And it may not be the same. If you're in a multi-system or multi-hospital system and you got a pediatric, you're going to look at a whole lot different things than you will in your adult community. Be specific to your population. And again, it doesn't mean that if you generally do not care for suicidal patients that you have to do that assessment, but consider the possibility that you could get one of those patients. That could happen. And most of you probably have already experienced that. Sometimes they will also, during their annual skills. CMS does recommend training every 2 years as a good, nice, gentle reminder. So let's say you do get a deficiency or something's identified. They do expect you, CMS expects you to correct it within a certain time frame. The regional office does that time frame. They set it up. That's usually through your Department of Health. Now, if you're accredited, you have deemed status with, say, Joint Commission or DNV, that will be the same thing, that they will make up, the state agency will determine what is the time frame for you to make this correction. Now, sometimes it is unreasonable to expect you to comply with it, with that time frame. So only CMS can give you additional time. Ligature risk, there's no waivers for a ligature risk under Life Safety Code. So don't even ask to have it granted because they won't give it to you. Corrections usually have to occur within 60 days from the date you get that report, and they will come back. So when I mentioned CMS is now back doing their surveys, this is one of those that are top on their list. If there were multiple deficiencies prior to the COVID shutdown and they had to do with ligature, they're going to be back, and you'll be first on the list. Now, your ability to comply may be a financial burden. And I'm talking where they're saying this entire wing has to be redesigned because it is not ligature safe, not ligature resistant. And so what usually has to happen there is, of course, you have to have board approval because you got to spend a lot of money to do this. And the money isn't there right now. That was non-anticipated capital expenditure. And that also means that, okay, we got to make these changes. That means we have to go out and get bids for it. And what's the availability of materials? Can we afford it? And how much time will that take? How much access is needed in order to make those changes to make it safe? As far as the citation, if they do not pose an immediate jeopardy situation, Again, they're expected to be corrected in that time frame given to you by CMS. That includes when the hospital has removed that immediate threat. So like I said, that doorknob and the lock that came off that door, they took care of it immediately. You have to put interim measures in place as part of your plan of correction to make sure it doesn't happen again. And that period starts once the hospital's notified of the deficiency. So again, once you get that deficiency report back, that's when the clock starts running. Now, only the state agency and the accrediting organization can recommend to CMS that you be given more time. So the surveyor comes out, they see the deficiency, and they know, say you're an older hospital, and it's going to take time to get this deficiency done. And you've told them, hey, this is what we're looking at. We've got to go through the board. It's going to take 3 months. We've got to get the materials. We've got to plan the expenditure. Only the state agency or the Joint Commission deemed status can go to CMS and say they need more time. And they're the only ones who can recommend it. And again, you have to put measures in place to mitigate it. That may be one-to-one sitters. And like I mentioned, having a sitter watch 2 patients, that's not one-to-one. And by the way, that observation includes when they sleep, go to the bathroom, take self-care. They also mentioned there are other alternative nursing protocols that the American Psychiatric Nurses Association has recommended. There is some interesting research from that association. They call it continuous special observation. There can be some adverse reactions. Sometimes you got a paranoid or agitated patient and there's somebody constantly watching them. That can escalate that paranoia, can really make it even worse. So again, back to the request for an extension. If you do need an extension to make that time frame, you have to give some information to CMS to support that. What's your plan of correction? What is the mitigation plan in the meantime? Why can you not meet that correction time frame? How effective will your mitigation plan be in the meantime? And then kind of updates. This is when we'll be giving you updates. And that's when CMS may also say, we want updates this amount of time. You give that request to the accrediting organization. If not, send it to the Department of Health, your state agency. The regional office, the central office, they will send a recommendation for approval. They usually respond and copy whoever came out and did the survey, whether it's Joint Commission or the state agency. And you at least, like I said, have to give them progress reports. Give them an update of what's going on a monthly basis. Include your invoices, any communication you have with vendors, especially when there's been a delay. So that's when you need to get an extension. So let's say now your surveyor's on site. What are they going to do? They'll watch how you do your environment of care. They'll look at housekeeping carts. Have those been secured? Are they away from these patients? Usually in some of these areas I've seen where the cart will stay behind the nurse's station. Don't ask me why, but they keep it there or secure. And the person will go in and take what they need with them into those rooms. So it never leaves their sight, or at least never leaves their hands sometimes. They'll talk to your staff. Again, make sure they're trained to look at the risk. And let's say they do find one. They'll ask your staff, well then who do you report it to? What do you do from there? Where do you take it? Do you write it down on a piece of paper? Do you send an email to somebody? Or do you go direct face-to-face and say, I have a concern about this? And if so, where does it go? They'll look at the policy and procedures within that, within the facility that determine how does the hospital itself define continuous visual observation. They'll look at the policy and procedure to see how you keep track of unwanted visitors, any contaminated material that you have to throw out and secure if nothing else. And how do they secure unsafe items? They'll look at the hospital security efforts to make sure patients are also safe from risk of suicide or self-harm. And you have to provide appropriate and adequate security to protect patients so that they don't hurt themselves and they don't hurt others either.